Well, my name is Dr. Luisa Bronte, and I'm a general dentist practicing in Birmingham, I guess you should call it Mountain Brook, because the city is Mountain Brook. And this is in Alabama. And I been practicing at this new office. I recently bought this office, and it's been here for about 6, 7 months already. I was doing an associateship before, and so recently I made this transition. Some of the things that you'll hear me talking about here in this lecture today are probably from my previous job. Some are from the new one. I My office is a full service office. We do everything. We do a conventional dentist. I mean, I guess standard dentistry, bread and butter. But we also do implants, aesthetics. We do small designs, full model constructions. So I do have a little bit of knowledge about everything. I love the term super GP. That's what I've been striving for my entire career here, and that's what I like to focus on. And yeah, I tend to get a little excited when I start talking about things that I like. So I might start speaking a little fast. If I say something that you don't understand, I also have an accent. So if there's something that you don't understand, or you probably have doubts about, just write it down. We're gonna have a little bit of time at the end for Q&A, and just write those questions down, and I'll be more than happy to answer those at the end. For those of you who are wondering where the accent is coming from, well, I'm originally from Cuba. There's a little town in the middle of the island that is called Ciego de Avila. I guess I should call it a province, not a town. And I'm from there. I've been in the States for about 14 years, so I'm still learning a couple words in English here, but it's been fun. And as you already know, we're going to be talking today about anterior implant aesthetics, how we can manage this. This lecture is mainly dedicated for the general dentist who likes to do a little bit more than just the general regular bread and butter dentistry. And I like to start with some learning objectives so you guys more or less know what we're going to be doing today. After you leave this lecture, you're going to absolutely gain some confidence in tissue management and extraction techniques and how to obtain good aesthetics results with anterior implants. You're also going to understand how to do the provisionalization steps that require good aesthetics, and you're also going to become more familiar with some of the bonding protocols and some of the things that you need to know to obtain these kind of results that we expect, right? So let's say, for example, we're going to divide this lecture into these steps. We're going to go ahead and start with the treatment planning first, and we're going to review some of the rules that you need to know for implant placement. Let's say you're not placing implants. Don't worry, you still need to know some of these rules, because if you're getting things from the periodontist, you need to know how you're going to approach these cases. How are you going to you need to have some basic knowledge about this. And if you're already placing implants, you haven't placed anterior implants just yet, but this is going to be great refreshment for you. And after we talk about those rules, we're going to go ahead and talk about a little bit of surgical guide fabrication, tissue management, temporary bonding protocols, some of the things that you already probably read when you registered for this lecture, right? So when I first started dentistry, and they really drill into your head when you're in dental school that you're not supposed to do any anterior implants yourself, that you have to get trained, that you have to be super proficient on this, right? That is true, right? But what is not true is that you're not supposed to do these cases. What you need to do is get trained, see lectures like this, obtain knowledge, go register for more courses. But the most important part here is that you have to be prepared, right? So, for example, you get this case coming into you and tells you this tooth broke. You take a look at this tooth. First thing that comes to your mind may be, let me refer to a periodontist because this is an anterior implant, right? Well, if you're really trained and you know how to do this and you really want to do it, you could do these cases yourself. I found out that when I was sending things to the periodontist and the oral surgeons, some of the times these things came out really good, but sometimes I was not really happy with the results. And I took a look at those things and I was like, wow, I could probably do a better job if I was doing these cases. And that's why I decided to start doing these cases myself. So, for example, in this case that we're going to be discussing today, this patient came in. This is a 37-year-old male that comes to the practice, and tooth is broken down. There's an endo in this tooth, number 9. There's obvious caries in that tooth. and there's non-drug allergies. The medical history is non-contributory. The patient does not smoke, no diabetes. The dental history, probably he went to a dentist a couple years ago. He said 2 years, but I'm sure it was more than that. But so you can see a little bit of plaque and calculus around the area. All right, so you see this patient. What is the first thing that comes to your mind? Well, it's a couple options here, okay? We have a zirconia crown on number 8. We have a natural tooth on number 10. And we have a tooth that obviously need extractions, right? We got to start thinking about treatment planning for this area. What are some of the options that we commonly offer to patients? Number 1 is implant. The standard of care for a single tooth replacement, and according to the ADA, is an implant, right? In a lot of places, we're probably going to get a bridge in this area. Hopefully, you don't get a removable denture, an RPD, or what is called a flipper in this area. And there's always the option of not treatment, and we always have to be conscious about that there's always the option of not treatment. Not treatment is good for some patients, but in this particular case, the patient did want to do some treatment, right? So we take a look at the CBCT, and the first thing that I noticed in this particular CBCT is look at how thin this bone is on the facial aspect. That tells me that I have to be super extremely careful when I'm extracting this tooth. If you don't have a CBCT in your office, please do not attempt to do this type of cases because the anterior implants, you definitely have to have more information about the bone health, the bone quality. So that's one of the things. Posterior implants, I wouldn't do any case without a CBCT, but you can get by with some posterior cases, but not anterior. Don't do any anterior cases without a CBCT. So the first thing that comes to my mind here, well, we gotta place an implant in this case, right? Where would the implant go in this particular case? Somewhere around this area, right? Let's just review some basic rules here. If we try to place the implant anywhere towards the facial aspect, you probably are going to perforate this focal plate right here, and that's not where you want to be, right? So the minute I see this, I mentally prepare where the implant would go, and I tell myself, yes, we definitely can do this case, right? All right, so what are some of the techniques that we're gonna use to extract this tooth? This lecture will probably require 4 hours if I wanted to show you every technique that is out there to extract teeth conservatively and extract teeth minimal trauma and all that. So I'm really gonna try to run quickly and give you a crash course of maybe 5 minutes on how I would approach this case and what type of instruments I would use, what type of technique I would use in this particular case, right? So the first thing that I'm gonna do in this particular case is I'm going to avoid at all costs. I'm always going to avoid flapping, and I'm going to preserve that papilla. If you raise that papilla, forget it. You're not going to get good aesthetics. You have to be so prepared. If you raise that papilla, good luck with that. You're probably not going to get a good aesthetic outcome if you do that. So the next thing that I'm going to do, I'm going to just call it thin burr, right? Because some of you may have different burr types. I'm not giving you a specific type. I put mosquito burr or number 859. But there are a lot of good burrs out there that you can use as long as it's a very skinny burr that you use in this particular case. And how am I gonna approach this case right here? If I try to elevate this area, I'm probably not gonna have a good purchase point. So I'm gonna have to use a thin burr. I'm just gonna put this burr as an example. Do I use this burr all the time? Not really. I'm just putting it as an example. But I do use a very skinny burr every time I'm doing this particular cases. What am I doing? Let's say this is the case right here. First thing I do, you see some blood in here. I got a periosteal elevator, and I try to tuck it around that tooth, and so at least raise that periosteum just a little bit. And I'm going to use this burr. I'm going to use it in a circular motion around the tooth, about 2 to 3 millimeters, just to break that lamina dura, which is the outermost, the hardest part of the bone. Once you break the outermost, the hardest part of the bone, whatever is below there is usually a lot softer, and it's usually better. It's usually more, it has more give into it. And you can work around this a lot better, right? If you saw a little bit of composite right here, I put a little bit of composite there just to strengthen the tooth because it had cavities, right? So I go with a burr, circular motion around this tooth. And what you don't want to use, as I was saying before, what you don't want to use is those burrs that you use for conventional extraction. Do not use a 557. Do not use any of those burrs, because if you use any of those burrs, you're probably going to end up eating all of this bone right here and eating all this bone right here, you're probably going to create recession at the end. So I use a very skinny burst, circular motion. I probably, in this particular case, avoided the facial aspect of it because there's a very skinny bone on there. As you can remember from that CBCT, there's barely 1 millimeter of bone in that facial aspect. And I'm going to show you the steps. I'm also going to show you the good, the bad. Every time you take a lecture, people usually show you what works, what beauty of it. And you're going to see that at the mid-lecture, I'm going to show you some cases where things don't come out probably the way you want it to. And I think that's the best learning experience you could have. If I show you all the things that come out really good and all my successes, you probably will not learn. You have to learn from the failures. You have to learn from some of the more difficult cases, right? This particularly was a difficult case. That's why I picked it. And I want to show you what happens. I'm also going to show you a couple more cases at the end where it was not so easy as well, and what I did to get those cases done properly with good aesthetics, right? So the next thing I use it in this case is a regular conventional 301 elevator. If you have one of your choice, go ahead and use it, and you're gonna have to have some armamentarium. For example, if the tooth breaks, which in this case it did break, you can use a endophiles, and in this case it actually worked. I'll tell you what. The endophiles do not really work for me all the time. They do work some cases. The only time that when they work is when the tooth is actually mobile and you have some mobility on the tooth. If they're not mobile, then don't even attempt it because they're probably not going to work. And I'm going to show you what you're going to do if the tooth, for example, this is a broken out treated tooth. The tooth broke. It crumbled down all the way down to the tip of the tooth. That's what I'm showing it to you. If I show you a good case, an easy case, you're probably not going to learn anything. So in this case, it did crumble down all the way down to the apex of the tooth and I had to get it out in pieces, right? So when I get this out, I'm going to have a lot of patience. You have to have a lot of patience. The endophiles do break. You put them in there. If you use two files, it works better sometimes because you can wedge one against the other one. You can kind of pull that tooth out in one motion, right? So when I extracted the tooth, I put a little bit of gauze on there just to make it pretty. This is how more or less what I got in here. If you can see, I preserved most of the papilla. I want to say all of the papilla. All the papilla was preserved in this particular case, right? So that's how I got the extraction atraumatically. This is what I call it, atraumatically, because there's barely no trauma or minimal trauma to this area. And it actually didn't take that long. It was difficult, but it didn't take that long. All right. What we're going to do when it's a difficult extraction, right? Second patient came here. It's not the same patient. Number 8, look at that tooth. Wow, crumbled down all the way down. What am I going to do to extract this tooth? It's so difficult with this amount of decay, right? Cases like this, remember what I was telling you. If I show you the easy ones, you're not going to learn anything because anyone can show you on a good Instagram post and very well edited. Here's what I did to get this beautiful extraction and all that. This is not the goal of this lecture. The goal of this lecture is to show you the difficult cases. What are you going to do as a general dentist to combat these cases? That way you don't have to be referring so much out to the periodontist. And there's a lot that I can talk about. In 1 hour, I probably will not be able to tell you everything that I want to say. So I'm probably going to rush over these extractions really quick so I can also show you some of the other stuff that I want to talk about. So what did I do in this case? Difficult extraction? Take a look at what I did. I don't touch the papilla. I don't touch the facial or lingual aspect of the bone. You get a scalpel, you measure the tooth in the x-ray, you measure the tooth outside of the mouth, and you correspond that measurement, do a little incision down here, with a circular, you open the bone in a circular motion, almost like you're doing a epicoectomy. I do a lot of those as well. I love epicoectomies. And a lot of I work in a practice that I do a little bit of part-time jobs, and that I get a lot of referral from other dentists of failure of root canals. And I'm lucky enough that nobody else does epicoectomies in this practice. So I'm very proficient at doing this. So if you do this, you have to be careful. You have to make sure that you get properly trained how to do this, right? So you open a little bit of at the apical portion, you get any instrument that has like a cryo elevator, and you push that tooth in this direction. It comes right out. It's a perfect motion you can do in this tooth. And guess what? You can do an immediate implant in this case. You just place the implant where it goes, you put a membrane, a bone graft, and don't even worry about that because that's going to be so far from the implant is that you're not going to have any problems up here. So that is what I do when I get a difficult extraction, a bone graft that I place an implant. Again, this is a different case. We're not going to talk about that one. We're just going to focus on what it is. And then you make it temporary for this tooth. and see how I was able to preserve the interproximal papilla right immediately after, right? All right, let's talk about implant positioning for just a second here. And even if you're not placing implant, you still need to know some of these rules. So what are some of these rules? You got to be at least 5 millimeters from the crestal bone to the papilla. If you're not 5 millimeters from the crestal bone to the papilla, if your periodontist did not give you 5 millimeters from that crestal bone to the papilla, you will not get proper papilla growth in between those teeth. You're not going to get what you really need in there. And so what does this really mean? The 5 millimeters is from the contact point all the way to the crestal of that bone right there to get that papilla. You're gonna be at least 3 millimeters away from the CJ of the adjacent teeth. What does that mean? Adjacent teeth, CJ around here. So you're gonna be at least 3 millimeters from that CJ of the adjacent teeth. Another measurement that you need to have, you have to be at least 1 millimeter below the crestal for immediate implants. Reason why? Because you will always gonna get some bone recession. You'll be lucky if you don't get bone recession, but why risk it? Just be 1 millimeter below the bone level, and you will be just fine if you do this, right? And the other golden rule that you're gonna have for these particular cases is you're gonna have to be at least 3 millimeters beyond the apical bone. If you're already placing implants, you probably know about this one already. So what are you gonna do? Whatever the apex of the tooth is, you're gonna be at least 3 millimeters there. So let's say you're not placing implants, right? Sure, you may say, why do I care about this? Easy. If a periodontist sends you a case and it's not 3 millimeters beyond what that tooth was, you're not having good primary stability. So you cannot immediately do immediate loading in this tooth, right? All right. So other basic rules. You probably remember this from school, or you've seen these in other cases. Let's just run through them really quick because they're probably more common than the ones that I just gave you right now. You're gonna be 1.5 tooth from adjacent tooth. So any implant from adjacent tooth is going to be about 1.5 millimeters. If you're less than that, you're not going to have growth of papilla. You're going to lose that papilla immediately. You're going to be about 3 millimeters from another implant. If you don't respect these rules, you're not only going to have papilla, but you're going to have bone recession. You're going to lose all that bone around that area right there. I guarantee you that. So the other things you need to know, when you're placing an anterior implant, particularly, you want to be between the cingulum and the incisal edge when you place that implant. A surgical guide would be preferred in these cases. I try to use surgical guides 8 out of 10 times, maybe every time I place an implant. Every now and then I get a case where what I feel good about. I take the CVCT and I don't need it. I've placed so many anterior implants already that I'm very confident doing them. But most of the times I do use a surgical guide, and I recommend everyone to use a surgical guide because that is the most precise placement that you're gonna have. And the next thing that you're gonna do is you're gonna be at least 1.5 millimeters away from the facial bone, right? I know a lot of places you're gonna have 1 millimeter. Good luck with that. I try to be at least 1.5 millimeters away from the facial bone, especially if I have a thin genotype of the papilla. If the papilla is very thin, I try to be at least 2 millimeters, and I do my own. I also do my own tissue graft. If I have to do a little bit of grafting in there, I get a piece from the roof of the mouth. We put it in there. That's a lecture for another day. So let's talk about some other this stuff, okay? And I also consider gingivectomy. Let's say, I remember, not all cases come out perfect. So if you get a little bit of recession around that implant and you have to make it right, just do a little bit of gingivectomy and adjacent one. You could probably fake it a little bit there and have a good gingival growth, both of them. All right, so when I place this implant, remember what the red indicator that I had at the beginning, this is more or less what I want it to be. Take a look at that bone right there that I was able to preserve, right? That's less than 1 millimeter right there. I don't know if you remember from that. I don't have a way to measure right here, but this is about 0.7 millimeters and 0.5 at that particular place right there, and that bone was intact. It did not break. If you do it right, if you do what I'm telling you, you will have good success. This is when I placed the implant. The X is a little bit angulated. It looks like it's a little bit deeper than it actually is, but it is in the right position. It's about 1 millimeter below the bone right there. All right, so when we place that implant, now, other consideration. A lot of people tell me, wait, you're doing an anterior implants. Why don't you do zirconia implants, right? Well, zirconia implants are good. I've placed some of them, but there's very few cases when I do those. And the reason why, because they they could be a pain in the butt sometimes. The only time what I would do a zirconia implant nowadays is when the patient specifically tells me has a concern about some people ask you for like holistic type of stuff. They want metal on their mouth or something like that. Then that's when I would do a zirconia implant. The indication for them is basically high aesthetic cases. Tell you what, I can get really high end aesthetic cases with titanium implants. And all the cases when you have a higher smile line, that could be true because you could have some show through. But guess what? What you could do, get yourself a course in what do you call in tissue grafting and learn how to graft, which is not that difficult. I know they drill this into your head when you get out of school. They tell you the tissue, like the periodontists are the king of the universe. I love my periodontists. We're good friends. I call them every now and then if I have a question, right? But you could do tissue graft successfully as well if you get properly trained, okay? And then you have to make sure for zirconia implants that you have very light occlusal contact, or otherwise you're going to break it. It's going to be a mess to take it out. All right. More important than the zirconia implant, what you really have to take care of here is make sure that you preserve the blood supply to that papilla. Don't mess with that papilla, otherwise you're going to lose the entire aesthetic of these cases. Minimize the scar. If you don't minimize the scar of the surgery, you're probably also going to have problems at the end. And the design of your surgery is also very crucial. How you make that incision cut, how you make that flap. You have to make sure that you get properly trained on this, okay? All right. Quickly run through everything that we talked about right now. Make sure you drill on the lingual of that apex, right? Okay, what the apex is, and drill on the lingual, go 3 millimeters past that. That's what's gonna get you primary stability. If you don't get over 35 newtons, then don't immediately load, right? Or you're gonna also make sure that you're between the cingulum and the incisal edge, and you're gonna be 3 millimeters below the CJ. It's just a summary of what we just talked about right now. Pretty much what we're doing is exactly what I was telling you right here. Okay. All right, some other basic guidelines. Every time I do an anterior implant, in my particular case, because I have to be at least 3 millimeters beyond the apex of the tooth, I don't do any immediate loadings if my implants are not at least 12 to 16 millimeters. Why? The root of a typical incisor could be anywhere from 7 millimeters to 11 millimeters, right? Around there. Let's say the typical incisor could have a 10 millimeter root, right? If you add 3 millimeters to that, that's going to give you at least 13 millimeters, which is what I would want in a case of immediate load. If you don't have that, don't do immediate loading because you're gonna mess. You're gonna mess it up. Okay. The other thing that you have to be very conscious is you have to minimize movement. All right. Remember, if the implant moves over 50 microns, anything that touches that implant is gonna fail. Don't do anything wider than 4.3 millimeters on the anterior side. And this is one of my biggest problems that I had when I was sending this to the periodontist. They were placing too big of an implant up here. We were getting recession after some time. And if you get a fenestration, don't worry. You should redirect the implant like I was showing you at the beginning. The one that I took out from the apex, and just redirect your implant, put a membrane bone graft, and you'll be fine. Remember that the implant will move toward the path of least resistance. So if you let that implant follow the same shape of the root, you're not in the right place. Implants are not placed in the same socket. Implants are placed lingual to that apex. If you're not placing an implant, this is probably not helping you too much, but what will help you is knowing that if somebody sends you an implant below 12 millimeters, do not immediately load it, okay? And the implant is your final drill for those that are placing implants. And don't rush. 50 RPM, 50 newton centimeters is perfectly good. A lot of people try to go really fast. If you try to go real slow here, you'll probably be more successful. All right, I use surgical guides all the time. Not all the time, eight times out of 10, right? And what do I do for surgical guides? Well, you can send it to your local lab. Usually, if you get in touch with your labs, they usually do a pretty good job with surgical guides. What I do is just take an impression. I take a CBCT. I tell them where I want the implant. I draw it and send it to them. Right now, I have a 3D printer in my office. What I do is I print them in-house. I only need a pilot hole. I don't need a full core surgical guide because with a pilot hole, it's usually sufficient for me. And I print them in-house. I use a software called Blue Sky Bio. And it's pretty self-explanatory. There's a lot of YouTube videos out there. You can get my information if you need to at the end, and I'll teach a little bit how to use your software. It's very easy to use, very user-friendly. It's free until you pay for the surgical guide at the end. So you can make the entire process. You can design everything, and at the end, you just get a surgical guide. And and you can just bring it on your office, right? So let's go to things that are a little bit more important in this particular case, because a surgical guy, you could probably pay somebody to do that for you. And something that is very important for anterior implant aesthetics, do not use conventional healing abutments. I mean, what's the right word for it? The regular healing abutments you get from the company, whatever company implant company you use. You want to fabricate your own healing abutment. If you don't do that, you're not gonna get that beautiful emergence profile that the tooth naturally have, right? You're gonna have usually a smaller one or a larger one. You will run the risk of even losing some of that papilla, right? So what do we do to make this custom-made healing abutment? All right, they're not difficult. A video will be better showing you, but let's just run through some of these steps real quick here, okay? So how to fabricate a custom healing abutment? First thing you're gonna use is a temporary cylinder. Many of the implant companies you use will have these out there, right? And a temporary cylinder, I use BioHorizons for all my implants nowadays. I play some Straumann's and Neodents and all that, but I really got stuck to BioHorizons because a couple of reasons. They're really good. They're one of the best ones out there. I'm not gonna argue whether who's best or not. They're usually, I'm gonna say, one of the best ones. And the reason why you also use it is because they're local. They're local here. Sometimes I've had patients. I'm very hyperactive. I like things done right then and there. In many cases, I'm getting patients telling me, "Hey, when can we start here?" And I tell them, "This afternoon, come at 4 p.m." My sister looks at me like, "You're crazy," and I'm like, "Yeah, I'm crazy." And I call Jeremy, my local guy, and he delivers that thing same day for me because I order so much for them that they already just it sometimes just comes and drops it up at my office for me. And that's the reason why I use BioHorizons, because I can get it almost same day. If I tell them right before 12 p.m., he'll usually bring it to my office. The next thing that you do here for a custom healing abutment is that you're going to have to use some type of flowable resin. Does it have to be a bioactive resin? If it makes you feel good, yes, right? Because there's a lot of research out there that is telling that you have to use a bioactive resin for that tissue to adapt and to that tissue to adhere to that. I'm not sure. You have to trust the research out there. If it makes you feel good, go ahead and do it. I'm just getting good results with what I'm using right now, and most of the time I just use a Bisco Dual Link. Reason why I use Bisco Dual Link is because it's a dual cure resin that you can put in around the tooth right here, right? You light cure it, and then once you unscrew that, this is the temporary what do you call the cylinder, right? Once you screw it in there, you square the resin around it, you light cure it, you take it out, and you polish that cylinder, right? Why do I use a dual cure resin? Just because sometimes these things are a little bit deep, and my curing light does not get all the way down here. So I just wait a little bit with that resin right there for it to harden on its own. And when I take it out, I may use something like maybe like Shuffle. And Shuffle, by the way, is a bioactive composite. It's a great composite with the Gynomer technology. You can do a lot of stuff. It's lecture for another day. But anyways, I use a flowable composite. I'll take it out and I do really, really good polishing, almost like a glass surface here, because if you leave this rough over here, that tissue is not gonna adhere, and then when you take this out, you're gonna have so much bleeding that it's gonna be really, really hard to control that day. What do I use for polishing? I use these polishers right here. These are not the only ones that I use. I just gave you these as an example, right? But you can use any other polisher that you use. As long as you get a really good polished surface there, you're gonna be fine. And then you go ahead and proceed to the temporization process that I'm going to show you in a second. To how do we temporize this implant right here? And take a look. When I say temporization, always be paying attention to my papilla, because that's the whole objective of this lecture. Excuse me. All right. So how do I temporize it? But the first thing you have to know about temporization is what materials are you working for? What materials are you having in this particular case right here, right? So what do I have? I have a zirconia tooth right here. I have an implant that I just placed in here, and I have a natural tooth. So you have to know your bonding protocols. What is some things that a lot of times I hear from people, you cannot bond to zirconia. Well, yeah, I'll tell you one thing, I can bond to zirconia, and I'm going to show you right now how I can bond to zirconia. My follow-up questions for those people are what products are you using? Are you using the right products to bond to zirconia? Because what I'm using, the technique that I'm using, is definitely perfectly good to bond to zirconia. And I'm going to show you what I do, okay? All right. So let's run out over some things what we could do here for temporization. What do I do for typically for a temporary immediate loading? We went over the things for immediate loading. We're not gonna go over that one again. So in this particular case, this patient checked all the boxes for immediate loading. We had a 13 millimeter implant. We had over 40 newtons torque. We had great positioning. We had everything. We were missing one critical factor: patient compliance. When I went over the patient, I told him what he could and could not do. He told me, "No, man, I'm not following those rules. Give me something where I can eat corn on the cob, where I can buy my apple." I say, "Oh, okay, sure. If that's your case, man, I'm not gonna give you immediate loading because you're gonna mess up my implant, and then you're not gonna remember now what I just told you, and it's gonna be my fault later, right? So make sure that if the patient is not compliant, don't do it." But I'm gonna show you what I did to temporize this case in a second. Well, what else can you do to temporize this one? What else can you temporize down, right? And this is just the immediate loading protocol that I was just talking about. Well, we probably went over this already, and I'm just gonna cut through this slide so we can focus more on the temporization process because I already explained this. Well, what else can you do to temporize this particular implant? Okay, you could do a temporary wing bridge, and this is the option that I picked, right? And I'll show you how to do that in a second, right? And the next thing you could do, oh my gosh, if you pick that partial denture, you're not doing high-end aesthetics. You're not loving this patient. If you place an implant and you give any patient a removable partial denture, a flipper, forget about any high-end aesthetic, forget about the papilla, you're not doing right. And this is one of my major problems when I was sent it to the periodontist. I would say a number 8 to the periodontist at the beginning, and they would say, "Oh, sure, can you send me a flipper so I can do it at the end?" I was like, no. Absolutely no. If you don't know how to do a custom heating abutment, if you don't do this, I'm not sending you my case. I'm not sending you a partial denture here because then we're not going to get what I want at the end. So hopefully you never do a removable partial denture for an anterior implants. I can tell you how many times I've even done a free temporary wing bridge because if patients don't want to pay for the extra, right? I just do it for free if you want, if you can, but do not do a flipper. If you do a flipper on an anterior implant, it's not good. It's not good. If your periodontist asks you for a flipper, tell them to get trained in how to do a custom healing abutment and do this at their office because this is not what you want, or just get a different periodontist. Okay, so let's just go over the bonding protocol really quick because we just said right now that some people think we cannot bond to zirconia. So what are some of the most common materials we use in dentistry? Well, we have lithium disilicate, right, which is the typical Emax that probably some of you already do, and the other thing that you use is zirconia. There's some other materials, but I'm just going to run through this real quick. What do you do to bond to lithium disilicate, which is just not the case, right? You pretty much do porcelain edge, you use silane. What do you use for zirconia? This is the key, air abrasion, and this is the second key, MD primer. If you don't have air abrasion, I'll show you another technique that you're going to use. MD primer, and the MD primer is what's going to allow you to bond to zirconia, okay? And what is the link to bond these things together is pretty much the resin. So if you get a tooth, what do? Phosphoric acid bond, resin. Zirconia, abrasion, MD primer, and resin, right? So quick summary slide what you're gonna need to bond different substrates when you're working with different materials, okay? What are some of the common adhesives that are out there and I want to call it universal bonds, but I should have called this slide adhesive, right? So what are some of the common adhesive that there is out there? We have a Scotch Bond universal adhesive. We have All Bond Universal, which is what I use. In my opinion, is one of the best ones. It's not the best one. OptiBond Universal, iBond. You probably use one of these or a version of one of these. I don't care what you use, as long as it works and you don't tell me that you can bond to zirconia. Then the first thing I'm gonna ask you is what materials are you using and are you doing it correctly? If you're using any other adhesive, I'm using this right here. If you're using any of these right here or any other adhesive and you're getting great results, continue using it. If you're using any of these adhesive and you're not getting the results that I'm getting, yeah, you should try something like this, okay? Because this is how I can get good results, and this is what I can do to get the aesthetics that I can get. All right, why do I use All Bond Universal? Because it's very simple. They did the research for me. They've been doing this thing for 30 years. It comes in one bottle. I have to be mixing these things together and all that. It's got a great low film thickness, less than 10 microns. Tell you a quick story real quick. How am I doing on time? Yeah. Okay. So I'm gonna tell you a quick story real quick. I had an assistant come with me, help me out one day, and that's when I bought my office. I didn't have All Bone Universal. I had a different adhesive. I'm not gonna talk about any other adhesive. I'm just gonna tell you the story. I had another adhesive at the office that the previous owner had, and I'm drying this adhesive, and as I'm drying, that the assistant, who's not supposed to know this, asked me, "Why does that adhesive look so thick?" And in my mind, it clicked, and I was like, I preach about this all the time. Why am I using something that is not what I preach about all the time? Next day, I went ahead and bought me 5 bottles of this because I was waiting to get a little bit of money so I could start buying this stuff, right? I didn't care. I just went ahead with my own money. I bought 5 bottles of Bisco because this is what I know works, right? Why do I also use Bisco? Because it contains NDP. Even though I do use an NDP dedicated primer when I bond to zirconia, I keep it just in case for those moments where you're really, really in a hurry, and we know those moments that you ask for your assistant, she looks at you and you're like, what am I doing? What do I need to pass me down? And you don't have the NDP primer next to you, then you can use this really in a moment of hurry, and you could go ahead and put that All Bone Universal, and it works just great because this has NDP primer. It's also moisture tolerant. You don't have to be super dry with this, and it works with any technique. If you like total edge, if you like self edge, if you like select, whatever technique that you use, this works just great. And it's also compatible with the with dual cure cements. You need to know your adhesive, and because a lot of times I talk to other friends, clinicians, and tell me, yeah, when I bond, I use X adhesive with this dual cure resin, and I'm bonding. No, you're not bonding because your adhesive needs an activator, and you're not using an activator. So make sure that adhesive that you're using does not require an activator when you're bonding to dual cure resins. And I guarantee you're going to be surprised when you get back to your office and you realize that you've been doing all this wrong all this time. And that's why your crowns come out. And that's why your crowns debond, even though you're following protocol. Okay, why else do I use All Bone Universal? Well, this is an example of different Scotch bond, PVI bond, OptiBond. This you can see some of the letters on here. Probably you recognize some of these. The reason why I use All Bond Universal is it's a twofold here. One of them is water concentration, and the other one is the pH. So what's with water concentration and pH? Okay. For example, this is a Scotch Bond Universal. The water concentration in a Scotch Bond Universal is 9.8. The water concentration is cut in All Bone Universal is 2.5. So look at that. It's almost triple or quadruple. I don't know. My math is not working out right now here. So what does that tell you? When you're trying to dry that solvent in that adhesive in Scotch Bond, and they tell you 10, 15 seconds, do you really think you're actually evaporating everything in 10, 15 seconds? You probably are not. You know how we dentists count. We count 1, 6, 15, go. Right? That's how we do it. I'm guilty. I do it all the time. When you try All Bond Universal, you're going to realize that when you air drying this bond, you're going to see how fast it stops moving because the water concentration is so low. And also, the second reason why I like Scotch Bond Universal is because the relationship that there is with water concentration and pH. If you remember from chemistry, the more water, the lower the pH, the more acidic. What's with pH? What's the big deal about pH? The more acidic, you know what's gonna happen. You know what's gonna happen. You're gonna hydrolyze that bone. You're gonna break down that bone. That's the reason why there's a higher bone strength on All Bone Universal than any of the other adhesives that I've tried so far. That is not just my personal opinion. That is research. You can Google it. You can find your research out there. All right, enough of bonding right here. This is what I use. What did I do to temporize this case? I used a wind bridge. How do I do the wind bridge? I put it to my tooth, to my tooth right here, and to my zirconia crown. What did I use? Something that is called rebond, right? Rebond. You can buy it. You need special scissors to cut it. You cannot cut it with just regular scissors because it flakes out. And the way that you're supposed to use rebond, you pretty much talk it to the one tooth right here, and redirect it to the, once you talk it to the tooth, you bond it here, redirect it to the adjacent tooth. And once you have it in the adjacent tooth, you bond it to the adjacent tooth. You're supposed to wet the rebond on an unfilled resin. If you use a filled resin, it's going to get hard by the moment you try to bond it right here. What are some examples of unfilled resins? You get a whole list right here. I'm not going to go over it, but you can kind of research what type of material. If you're using 3M, you should use something like this for for that. If in my case I'm using visco, I cannot use universal because it's a field resin, so I would have to use something like this, right? All right, so you bond that. It's a temporary wind bridge. You've probably done tons of those, and you just put it on the back of it. And what do I use for my teeth? Well, I use an all bone universal on my tooth. And what do I use for my zirconia? I use an MDP dedicated primer. What is that? Z Prime Plus is a great one, and I get it from Bisco as well. It's a great MDP dedicated primer. And not rule number one, if you want to get something bonded, isolation. This is not perfect isolation. I know I'm doing a slit right here, but guess what? It's a temporary, so I don't really care. It's only gonna be here about 4 months, but still, I use some sort of isolation. Rubber dam in my office is a must for everything. We use rubber dam for everything. I don't do it for wisdom teeth extraction because I have nowhere to clamp it to, but I do rubber dam every single time, every day for everything. You have to use it. And how do we do it? You pretty much put a resina behind there, and that's how you bond it right here. And that's how the temporary wind bridge works in this particular case. This is kind of somewhere in the easier side, but as I was telling you at the beginning, always take a look at the papilla and see how I've been preserving that papilla and every step of the way. Okay, so how do you remember that wind bridge, that ribbon that I had? The way that I do is that once I get my temporary fabricated out of composite, I create a window in the back like this, and this window in the back is what you put over the resin, and I bonded a natural tooth to guess what? I bonded to a zirconia. So for those of you who say that you cannot bond to zirconia, this stayed in the mouth for 4.5 months until I removed it to take my impression, right? You have to make sure you're not in occlusion. If you're in occlusion, not even the tooth is gonna break. Everything's gonna break. So this is how you do it, okay? It looks a little bit ugly because this was stuck. This was taken post-operative at the moment of removal. So this is a 2-week post-op of this particular case. After we place the temporary. An alternative is if, for example, if you could do you could do the window and then you can put a ribbon on the back and you can bond each individual fiber to the adjacent teeth. This is just an alternative. If the first one was a little bit difficult, challenging, you can do this as well, and you can work as like a single wind bridge that you can bond to the back of the teeth of what you're working on. Take a look at this case real quick. Let's just go over this one really quick. This is not my veneers. This lady came as a referral from another dentist who saw that I was doing anterior implant aesthetics and told me, "Can you get this patient in tomorrow?" I said, "Absolutely, yes. You know how I am. Let's get this patient tomorrow." All right. So what do we do here? Let's extract this tooth. Veneers were done in a different place, not my veneers. First thing I did is I take the tooth out. Remember what I said? Atraumatically. Remember what I said about not all cases are easy. Some of them are really hard. In this one, the bone of this case was so lingual angulated that my implant came out on the facial. I know, it came out on the facial. So don't beat yourself too hard. And so what did I do here? I got the same crown that the patient had. I put it over the patient. I put a little bit of dual link there, right? I put the same crown that the patient had over there, polished it around. And what I did at the end, I put it and I tightened it with my cylinder, temporary cylinder, crown of the patient, and flowable resin polished like a glass, right? A little bit of Teflon tape in the center. And this is what you get 2-week post-op. Guess what? Remember that black triangle was there. That was not mine. That's the way that's how she came originally. You see that papilla was very receded, right? So 2-week post-op, right? Guess what's gonna happen at 6 weeks post-op? Can you see a little bit of growth of that papilla right there? You have to see it. You see that black triangle? So there's a little bit of growth of that papilla at the 6 weeks post-op, which means that we're on the right track. I don't have a final picture because it was restored by a different dentist, but this is what tells you that we're getting growth of papilla, so we're in the right direction here, okay? Tissue contouring. Let's go over tissue contouring real quick. What do we need? Custom healing abutment, right? So when I got that healing abutment out of the mouth, the one that I showed you that we made at the beginning, look at how beautiful that tissue looks around there, not bleeding at all, just little pink around there, a little this red spot. None of this is bleeding. This is how exactly looked when I took it out of there. Look at that at the 4.5 month mark. Look at that tissue, how beautiful it looks, how healthy it looks, right? Right. This is at the 4.5 to 6 to 5 month mark when I took it out to take the digital impressions, and I do digital all the way. I did what do you call scanning body. You probably know how to do a scanning body if you're doing digital impressions already. I scanned it, and I did a zirconia abutment just to be a little fancy here. I didn't have to really do a zirconia abutment. I do zirconia abutments more often than I do zirconia implants, a lot more often. But this patient did have thick papilla, thick gingiva right here, so it probably was not needed. The next tip I'm gonna give you, every time you do you feel this things for the screws right here, you probably want to use Teflon. Please do not use cotton rolls. That stink. Every time you get that out of there, especially from root canal, those cotton rolls are really, really, really stinky. So you probably want to use something like Teflon tape. It costs 50 cents in Home Depot. Sorry, I did not say that. Just kidding. Anyways, all right, here we go. So cementation protocol. So when I do cement the final crown, I used what we call the APC concept, which is basically a bonding to zirconia. And how do you do that? It's with a 50 micron of aluminum oxide, 1.5 bar, chairside micro etcher, right? What if you don't have this? Because a lot of practices do not have this. Well, you can use something that is called IvoClean, which you probably have it, or Zirclean, which is great. This thing works great. It's a high pH solution that cleans your zirconia just really good and remove that phosphate group. The purpose of these cleaners right here are nothing but removing that phosphate group that you have in zirconia. So zirconia has a really high affinity for phosphate. And remember, saliva, that's what it has, phosphate. So when you put that and that zirconia gets contaminated with saliva, what's going to happen is you're going to weaken in that bonding process if you don't remove that phosphate group. So what you got to use a cleaner like Zirclean, and that's going to help you improve your bonding. The other thing that I use for cementation, as I was telling you earlier today, I use a dedicated MDP primer. Some of the ones out there, Z Prime Plus, Clear Fills. You can use something from Kirk as well. I love Z Prime Plus. I get everything from one company, and they get great results. And what you could do is a composite resin to bond the zirconia. If you're really trying to bond the zirconia, it doesn't work with glass, however. Some of the resins out there, I'm just going to give you an example. You're probably using one of these right here. I use Visco. TerraSem is my go-to for almost everything I do nowadays, and I'll tell you why in just a second. You could also use Dual Link. They have a great resin cement. 3M has got some great products that you can use as well. I'll tell you why I choose TerraSem over 3M in just a second. Ivoclar has got, this is just some of the resins that you could use to cement the crown. You might be asking yourself, why is it talking about cementation? Well, we're on the final aspect now. And I'm giving you an introduction what I'm going to do to cement my crown here. All right, so why do I use TerraSem? TerraSem is just great. Ever since I started using it, it changed the way I practice dentistry. It's got a really great low film thickness. Super easy to clean. Super easy to clean. You tack your TerraSem and you can peel that out really quickly, real nicely. I was using 3M before, and every time I cured that 3M, it was a really pain in the neck trying to clean that cement around the area. And TerraSem is really easy to clean. And the next reason why I use TerraSem, if not the most important one, is because the continuous calcium and fluoride release that it has. And it does that not just by 1 or 2 days. It does that continuously for several days after you cement that crown. So for those margins that we all know that when you put a crown in there, you look at that margins, you look like, oh my gosh, did I mess up here? What was I thinking when I did this margin? Well, this is going to help you a lot. This is going to help you a lot, okay? It's also dual cure, so you don't have to be worrying about if it's a zirconia, and you don't have to be worrying about if it cure or not, because it's a dual cure. This is very important. Acidic. You may be asking, what's the deal with acidic? Remember what you need. What you need to bond something, you need acid, right? You need acidity first for that initial bonding process. And it slowly transition to alkaline pH in minutes. You don't want it to stay acidic like other cements. If it stays acidic, you're going to have edemineralized and dente. And what's going to happen is that it turns into alkaline in pH in just a matter of minutes, okay? And it's also, it's got a hydrophilic matrix, which allows constant ion exchange with the outside, and it helps to remineralize those areas where I was telling you, you could probably have a bad margin there, and this is going to help you in your cementation of crowns. It also contains NDP, so you don't have to be worrying about whether or not you have an NDP primer. I use a dedicated NDP primer, but I like taking steps, and I like doing things that are a little bit different. But if you just want to have it one step, NDP primers, bonds of zirconia are really good. Good luck trying to get that out of the zirconia once you get a primer, because it really sticks to it. And it's also radio opaque. So when you like here, you can exactly know where the cement is. It's very easy to clean. And it's very easy to dispense. You got some tips right there that is very easy to dispense. So this is what I was telling you about. the continuous fluoride release and calcium that you get from Therasem, and the minute you place it, it continuously does it, and over a period of days. And the most important part about Therasem is this right here. You probably are familiar with some of these cements right here. Oh, look what we have here, Reliax, right? GSM, Fuji, Panavia, right? You probably are familiar with some of this. Look what happens with Therasem right here. Look at the megapascal strength. If you like here, that Therasem, it's gonna double probably some of these right here. It's gonna double some of those. It's gonna triple the ones over here. So if your zirconia crowns are coming out and you don't know why, check your product. Check the research, see what you're using, because you're probably not using the right product. All right, so let's talk about what we were just saying at the beginning. I just gave you some of the products I use that give me good success. So this is what happened at the 6-month mark. This is my implant right here. Look at the bone levels, right? This X-ray was probably taken at the 7-8, probably a year mark. I think they was not taken immediately post-op. Zirconia abutment right here. What do I use for zirconia? Clean it with Zirclean, Therasem, bam. You cement it right in there. Look at my tissue right there. Look at that tissue, right? So what I was telling you is I'm a general dentist. I'm getting these cases. I'm getting high-end aesthetic cases right here. I'm doing anterior cases, right? I'm trained and I know what I'm doing. So what I'm telling you is not for you to go to tomorrow and start doing all these cases all of a sudden. What I'm telling you is just to get excited and get trained and start doing these cases yourself, because you probably will get a better success of what you're currently doing. And nothing wrong with referring out if you don't feel comfortable. It's just that I think I can get just as good a result, if not better, if I do it myself. What is my armamentarium when I'm doing these cases? This is pretty much what I use. Zirclean to clean, NDP dedicated primer, all bone universal is what I use for my universal adhesive. I use it for almost everything. This is one of the most versatile, one of the best adhesive. So if you tell me you cannot bond the zirconia, try this. Also, I use the Therasem for my crown cementation, Dual Link for my inlays, onlays, some veneers as well. I do with these, and I just use a bioactive resin here for all the other stuff that I do. And you may be wondering, this guy's been talking for such a long time. What happened at the end? How did that implant look? This is 1 year post-op, almost 15 months post-op. This patient's doing great. That implant's getting better and better every day. So, in my opinion, this is a good result. I wish I could do 10 teeth up here and do 10 veneers to do a better shade match. But I'm pretty happy with the results. I'm pretty happy how I was able to preserve this papilla. So it's something that I don't need to be referring out. And nowadays, I pretty much do everything myself in-house. I haven't not referred a single implant case in the past year or so. And it's because I think I can provide a good service to the patient. So hopefully this works as an encouragement for you to go out there, get trained, and what do you call it, and get better at these type of restorations. So before and after, where we started and where we ended up, and we have about 5 minutes for questions. If you guys have any questions, feel free to shoot them over. Okay, what is the alternative? Oh, sorry, I probably ran over that when I said it. What is the alternative step for zirconia in place of air abrasion? Great question. The alternative in that particular case is Zirclean. Let me get my video here. The alternative in that particular case is Zirclean, and that's what I use. You can use something like IvoClean. I'm more familiar with Zirclean, and I love Zirclean. It's a high pH solution. I can't remember what it has inside, but it's great. It removes that phosphate group really good, and allows you to get what do you call a great bond in the zirconia. And see. How about a screw retained crown on the temporary cylinder to sculpt tissue? Great question. And I actually showed a slide about that. Remember that slide that I showed you about the case that was referred to me by has some veneers? That's what I did on that particular case. So you put the abutment in there, crown over it, and you use the same unit as a way to what do you call to build that, sculpt that tissue around. If the patient has perio, are there other things that I must consider? For sure, you gotta get that perio under control. I would not place an implant under in a high in an environment where there's a bunch of bacteria there that could what do you call mess up my implant side. Get the perio under control. I would advise usually when there's perio, you're gonna have what we call black triangles, and you just have clear expectation for the patient. Let them know that we're not magicians, right? So every now and then you're not gonna have a perfect papilla, so as long as you have good expectations for them. All right. Octavio says that he likes Theracem also. That's awesome. For tissue, stay nice and healthy with the these cements. That's awesome. Any other questions for me? Let me see. Let's see if I can reading them correctly. And thank you for those of you that have said nice things about the lecture. It's a great question. Do you charge for redoing an implant if the failure cause is the patient and isn't something like smoking and get the diabetes under control? I don't. I don't. And for a whole year, I had 100% implant success, and I had no problems there. I'm not gonna say I have 100 right now because I placed close to 1,000 implants now. Um, and yes, I've had a couple ones, but I would say I'm over 99% success in implants. And actually, the few ones that I've had to remake, they've been patient's fault. Or in all of them were due to diabetes, diabetes and smoking actually. And the reason why I don't charge is because it's kind of like a hard conversation with the patient. And one of the things that I do for my patients, I promise them, and in my first visit, if anything happens to this implant, I will redo it for free, one time. If it happens again, it's not my fault. It's your body rejecting it, or you're doing something wrong. Because I show them I have great success. People are referring implants to me. General dentist that is actually referring that I'm getting referred, right? So I tell them it's not something that I'm doing wrong, because if this is not happening with the other 100 patients that I'm doing implants, why is it happening to you, right? So, but I do tell them one thing is that I also think it's just nice for the patient, give them that security. I create what do you call? I give them clear expectations, but at the same time, you have to offer some sense of security, right? The clear expectations, but you have to be. I cannot be there. Oh, the implant may not fail. I tell you, it's gonna happen. The implant this might happen, but I've placed so many implants and I feel confident doing this surgery. And if something happens to it, I'll fix it one time. Now, if it happens again, then it's your fault. So yeah, but I don't charge them the first time. No. Hygiene instructions for protocol. It's pretty much what you give to for implant for just floss, brush, come every 6 months. For the first 2 years, I have them come every 4 months to check. I do that if I have some doubts about the patient. If for anterior cases, you have to make sure that you tell them not to overuse that implant. This is you do not ever buy it again and corner cup like my patient wanted to do. I scared him pretty good after we did that. We got such a good result that he actually promised me that he was gonna be good about that. And I told him that actually I was lecturing about this, so he had to really take care of it. So I definitely would make sure that tooth is never gonna be the same. You implant on the front tooth, if you don't take care of it, it's gonna fail. Somebody asked me, is Ceramir a good option as a cement for zirconia? It's a good product. They have a lot of research on that. I'm not here to talk bad about any products, and I don't use them. What I could tell you is, what's your success with it? Are you having good success? Are you having the crowns coming off? Can you bond the zirconia? Things like this. Um, I'm not using them. And I like my Bisco products a lot. Hey, have you tried a new shape and healing abutment for Bio Horizons? If so, do you like them? Yes, I have. I actually got it for free from Jeremy because I order a lot from them, and they actually gave me a trial product for free because I do a little bit of lecturing for them as well. And yes, they're great. However, for an anterior case like I just showed you, I still would probably make my own regular like I showed you, because when I take that tooth out, that tissue stays like that for right immediately after. So I want to capture and replicate the exact same tissue that I have at that moment. I definitely use those on the back, on the posterior ones, not an anterior ones. And anterior ones, I'm still old school, and I'm still using my own custom hidden abutments. Yeah, but those are great options. You get the smart shapes. I have them. Yeah, they're great. They're expensive too. You want to order them. You got any other questions for me? It's kind of hard for me to go back on fourth year when I'm talking. Well, if you don't have any other questions for me, just let me know. I think time's up.